Well, good afternoon, everybody. I want to thank each of you for taking the time to jump on to the third of the Tenex summer webinars. Today we're featuring Dr. Mederick Hall of the University of Iowa Sports Medicine Department. Dr. Hall is an avid Tenex user, has been with the company in terms of his usage of the technology for well over 18 months. At this point in time, Dr. Hall, to his credit, has performed over 150 cases utilizing the Tenex technology at this juncture. He was kind enough today to offer up his time and expertise to fill in all of you who have an interest in learning more about the best practices to optimize your outcomes with Tenex Health TX. So I will, without further ado, hand it over to Dr. Hall. I'd like it if everyone would please hold their questions until the end. We'll answer them as they come in. Again, you have the opportunity to type questions in via your control panel on the right side of your screen, or ask directly to the crowd by raising your hand. Rachel Thompson will be moderating that aspect. So, Dr. Hall, we're ready if you'd like to take it away.
All right. Thanks a lot, Jim, and thanks everybody for joining us here this afternoon. I'm sure everyone's rushing to finish up clinic like I was, so I appreciate your time, and hopefully we'll make this educational for everybody. And so we'll get started here first with just a disclosure. So I am a consultant for Tenex Health, just so everyone is aware. Otherwise, I don't have any other relevant financial disclosures for this talk. In terms of our learning objectives, we're going to briefly provide some introductory material. So we're going to discuss the rationale for percutaneous tenotomy and fasciotomy, understand a little bit about how the device works as well as its safety profile, and then get into what I think is the most important thing about today's talk, which will be identifying important factors in patient selection, and then how we can really optimize both our technique and our post-procedure rehab to get the best outcomes as possible. So just a brief introduction of who I am so everybody can kind of put the talk in that context. So I'm a primary specialty is physical medicine and rehabilitation. I did my residency at Mayo Clinic, then followed by a sports medicine fellowship at the Mayo Clinic as well, where I was trained in both diagnostic and interventional ultrasound. Currently, I'm the director of musculoskeletal ultrasound as well as the team physician here at the University of Iowa. I have a large referral base within the large university system, and so a lot of my patients are going to be referred to me specifically for consideration of these type of procedures, and I see a large amount of tendon-related disease as part of my practice even before I was beginning to use the TX system. I have 7 years experience with both diagnostic and interventional musculoskeletal ultrasound, and that's probably important just to recognize because I will be talking somewhat about some of the diagnostic features and characteristics, and so that's something that I'm very comfortable with and that I do as a part of my practice, and so that may be a little bit different for those of you who are not doing a large amount of diagnostic ultrasound, and we can talk about that and how you may be able to move forward if that's not a large part of your practice right now later on. And as Jim mentioned, I've been using this for a bit now, so not quite 2 years, so I have a decent amount of experience and done quite a few cases, and so hopefully I can impart some of what I've learned to everyone today. So we'll jump right in here. So we all know what the problem is. This chronic tendon disease is a major problem that comes into physicians' offices. Probably one of the most common things that we're going to see in a sports medicine practice, but really even in primary care setting. And so elbows, knees, feet, ankles, shoulders, there's millions, literally millions of patients out there every year with these problems. And unfortunately, despite them being very common, oftentimes they've not been all that easy to treat, and a lot of frustration comes about by some of these patients just returning without getting better, despite what's been ample amounts of time and treatment. In terms of treatment, the basics, rehab, activity modification, work for a lot of these, but, there's this segment of patients who just do not respond to that, and those are the ones that typically end up in our offices. Steroid injections have been done for years for this, but really have fallen out of favor of late. And this has largely been in part due to our shift in understanding of what this tendon disease really represents, being a non-inflammatory process, as well as some of the risk and lack of benefit that's come about whenever we've done, decently designed studies looking at steroid injections, particularly over the long term. Regenerative injections, such as platelet-rich plasma, have gained a lot of momentum over the last several years, but despite that, there's still really a lot of lacking in the evidence for their efficacy, and because of this, they're expensive. And so I routinely do not get insurance coverage for any of these type of procedures in my practice, and oftentimes it's a hard sell for patients to pay a large out-of-pocket expense for something that, even though we think it may be helpful, we don't have a lot of really good evidence on. In terms of percutaneous needle tenotomy, this is something that actually has decent evidence, although limited, but I've always felt that we could probably do a little bit better here. So we're kind of taking what we have available with the needle and fenestrating the tendon and restarting this healing cascade, and it works. But I've always felt like we should could have something that we've actually designed to do this a bit more effectively. Tendon scraping is something that many of you may not be familiar with, but it's applicable only for certain areas, Achilles and patellar tendons in particular, and has been effective in some short-term outcomes, certainly in my practice, and is supported in some limited evidence in the literature, but really doesn't offer the full treatment of all chronic tendon disease that the TX system would. In terms of surgery certainly can be effective, but it's invasive, it's expensive, there's a prolonged recovery time, and for a lot of these problems, the general orthopedist has not been overly excited to move forward with an open surgical procedure, given what we just mentioned. A couple of recent articles, I think, have really highlighted the frustration and treatment of some of these problems. And so this article by Coombs and JAMA back in 2013 looked at tennis elbow, and if you look at the conclusion and relevance here, it basically says that corticosteroid injections did worse than placebo injections, and physical therapy didn't help. And so two of the mainstays of treatment for this, you were really sort of shot down in this really well-designed study that I really consider the nail in the coffin of corticosteroid injections, at least for tennis elbow. And then just earlier this year, there was this rather strong title coming out of BJSM saying there's strong evidence against PRP injections for tennis elbow. And certainly, there's been commentaries and discussion about this article. Not everyone would agree that it's necessarily true, but as we move forward, we definitely can say at the least the evidence is certainly lacking and not where we thought it would be at this point in time for some of the biologic treatments. So what else is out there? Well, this all sort of started back, really 20 years ago with the phacoemulsification procedure for cataract. And so an ultrasonic handpiece was used to emulsify and aspirate that cataract tissue, and this really changed the treatment paradigm of cataract. And it's been something that's really become a mainstay, and it's been around for 20 years, so it's shown to be very safe and very effective. And so utilizing that as the background, the thought was, well, removing tendon tissue is similar to removing, a cataract. We're trying to remove a soft tissue from the body. And with open surgery, it's fairly straightforward. You open the area, you see the degenerative tissue, you take it out. Well, with diagnostic musculoskeletal ultrasound, we can see this tendon tissue actually very well, and I would argue probably better on ultrasound than you can actually at the time of open surgery. And so the goal would be, can we replicate this surgical procedure, but use ultrasound to guide it instead of having to open the area, and use a percutaneous instrument, borrowing from what we've learned from the phacoemulsification procedure. And so that's basically how the TX device was formulated. And so the ultrasound is used to identify the tissue and used to guide the tip to the pathologic tissue during the procedure. And as we see here, this is an example of a common extensor tendon at the elbow. You can see the obvious region of hypoechogenicity, which is the dark area within the tendon fibers that represent the tendinosis or diseased tissue. And then you can see the TX1 microtip being guided nicely into that area and then activated with the foot pedal to remove the damaged tissue. And so it's a relatively straightforward procedure. The nice thing is the safety profile, and really the targeting of the unhealthy tissue only. And I think that when I first heard this, I was like, I'm not exactly sure. That sounds a little too good to be true. But then, when you think about the phacoemulsification procedure and really removal of this cataract in the eye, I think it makes a little bit more sense. And so the frequency has really been optimized to break down this degenerative tissue while relatively sparing the healthy tissue, which is in contradistinction to other percutaneous type procedures that may use radiofrequency or some other type of heat that really are not able to make this distinction between healthy and unhealthy tissue. And we're actually able to remove the tissue with the irrigation and that comes through the sheath. And so not only are you breaking up the tissue, but you're actually able to remove the tissue from the body, which I felt was a big step and big advantage and a big step forward compared to the percutaneous needle tenotomy, where you're simply just fenestrating and breaking up the tissue, but you're not actually able to remove it from the body. So for those of you who have not actually had your hands on the device yet, it's fairly straightforward. It's an iPad-like interface. With really only a handful of controls that you have to work on that. It has a disposable handpiece, so everything that's going to be utilized for the patient all comes packed up sterile and gets thrown away, so it's very easy to deal with. And then there's a foot pedal that activates it, so you have your hands free to guide the device and use your ultrasound. This is just a quick little video clip that runs through in a cartoon model of what happens. And so there's a small little stab incision that's made. The microchip is then guided into that location, and then under ultrasound, as we just showed in the previous clips, you're able to see the tip going to the region of pathology. In this, you're able to see the 18-gauge needle and the fluid that comes around the irrigation sheath, and then through vibration of this tip, we're able to create ultrasonic energy that's going to debride that necrotic tissue, and then through the saline that's circulating around, actually aspirate this and remove it from the body quite effectively. So these are just some videos from a patient of mine, just an example of a patellar tendon. And so we see on the left here, the patella, this is the patellar tendon itself, and we have a small 27-gauge needle that comes in here to obtain local anesthesia. Typically only requires 3 to 4 ml of 1% lidocaine to get these patients very comfortable. You can actually visualize the scalpel coming through if you want. Certainly you could make this incision without having direct visualization as well, but you can see here nicely we can guide the scalpel right into the region, make our track for the device, and then here's the device as it comes in. So we can see as it's activated, you get these artifacts that are coming down underneath, and we're able to effectively remove the tissue. So in the bottom video, as we're sliding back and forth, you can see that after we've been able to debride this tissue, now you can see this sort of vacuole that's been created where that diseased tissue was taken out, and these small little bubbles that are shooting around in there as we activate the irrigation fluid, confirming that we've removed all the diseased tendon tissue. This is just an example of a separate patient with similar pathology. So when he came to see me, he has a pretty large partial thickness tear of his patellar tendon, as we see here in the long axis or longitudinal view, and here in the cross section or the short axis view. And 10 weeks after debridement with the TX device, as we slide back and forth on these videos, you can see that this is healed in quite nicely. There's no longer this hole in his tendon, and actually you can see fibrous tissue. It actually looks like relatively healthy tendon tissue that's bridged this whole area at 10 weeks, at which point he was completely asymptomatic and had returned to all of his activities. So the total procedure time is dependent upon the amount of pathology and the location, but typically is around 20 minutes or so, some more, some less. The microincision minimizes infection risk and really makes for a very, very minimal scar, if any, in most of these individuals, which they're pleased with. They can leave with steri-strips and tegaderm, and often we'll come back to you at 2 weeks, and you may have a difficult time finding where you were at. Local anesthetic has primarily been all that's needed for these, and I'll mention a few exceptions later in the talk with the plantar fascia possibly, but usually just 5 cc's or less of lidocaine is enough to make this an almost painless procedure for the patients. And then postoperatively, simply ice, compression, over-the-counter medications are typically all that's needed for pain control. And, I very rarely have to prescribe any opioid-based medications for these patients. So how does it work? And so basically there's two ways to think about this. One is via the, what I call the jackhammer effect. And so this is just electromechanical effect of the tip vibrating. And so basically just causing disruption of the tissue right at the tip from the longitudinal movement. And the other is a little bit harder to wrap your head around. It's this cavitation principle. So I don't have a PhD in physics, so I don't really understand this all that well. But effectively what happens is small little bubbles are produced, which then implode. And so when I first had this explained to me, I was trying to think about this, and I said, oh, it's like a black hole. So I call this the black hole effect. And so I don't really understand this. It's very complicated physics, but this is really the same principle behind any ultrasonic type of cleaning, even routine household things like your Sonicare toothbrush, has some of these similar characteristics. So we certainly know that these things work, although the physics are a little bit difficult to understand. And so, admittedly, there's a little hand waving whenever we try to get down to the physics of this. And so what I felt was nice was the study, that's currently in submission that tried to look at practically what actually happens when we do this. So if you take tendon tissue, tendinopathy model in an animal, and we actually do this, what happens? And it's something that general clinicians can understand. And so if you look in this tendinopathy model, you actually can say that yes, as we see in figure labeled D here, this abnormal tendon tissue is cut and it's removed. And so where the microtip passes through actually does remove this tissue. And then if you look during the healing process, you will see that fibroblasts are going to repopulate the evacuated region. So indeed you are removing tissue and then you are healing tissue in from where it has been removed. What's interesting is that when you look at this healing tissue, there is actually a restoration of normal collagen expression in ratio of 1 to 3. And so, albeit this is an animal model at this point, this would suggest that there is a possibility of actually healing in somewhat normal tendon tissue as opposed to just laying down scar tissue in this area, which I feel is very exciting. In terms of safety, if you apply direct energy to a normal tendon, they also looked at that and were able to show that with direct energy for 5 seconds, you really get minimal effect on that normal tissue. And so this again speaks to the safety that, while you're cutting through that abnormal tissue, the normal tissue, although altered slightly, certainly is not disrupted as we just saw in the previous histologic slides. So in terms of safety, I think this speaks, highly to the safety of the device. You're really affecting that abnormal tendinopathic tissue, and you don't have a very large kill zone, unlike some heat probes and radio frequency things that are going to extend outside of the area. And so that minimal collateral damage, at least for me, makes me much more comfortable at guiding this procedure around tricky areas such as the medial elbow, as we can see in the images here. And so here's the common flexor pronator tendon, and if we look on the transverse or short axis view, here's this abnormal region that we were seeing here, and here's our ulnar nerve. And so certainly we wouldn't want to be here with any device that's going to have a very large radius of damage to tissue with the ulnar nerve sitting right here. And so I've treated many of these and never had any carryover injury to the ulnar nerve, and I feel very comfortable about that. There are other safety tips, or safety features, I should say, and so there's an automatic shutoff, and so if your irrigation or your aspiration is stopping and you're not getting good backflow, it will automatically shut off the energy. The biggest safety is really probably the live sonographic guidance. So as you can see here, if you can identify these areas that you don't want to get into, such as the ulnar nerve, then you can really precisely guide the device right where you want it. You can identify the target region of pathologic tissue. So as I mentioned, some of these things we'll see on ultrasound, some of these regions of pathology would be a bit difficult to see if you were doing an open surgery. And so the pathology is really within the tendon, and if you're coming down even visualizing the tendon with the naked eye, you're going to have to dissect through it to see this region, whereas under ultrasound you can really see into that area, and I feel treat it much more adequately. And then you can also look around before and after, and so you can see where these things are. Oftentimes you can mark out the neurovascular structure so that you don't have to worry about where your incision is going to be placed, or if somebody has a little variation in their anatomy from the standard, you can feel much more comfortable about that before and during the procedure. So clinically, the big study that was published in the American Journal in 2013 again, sort of confirmed what we've talked about from a basic science standpoint. And so this looked at tennis elbow patients. 20 patients were done. And most importantly, there were no device-related complications and no patient-related complications, so it appeared to be a safe procedure. But then, happily, 95% of these patients were all very satisfied with the procedure. And you can see in the two graphs here, this is their VAS over time and their DASH over time. And I'll actually show these to patients because I find that, in my experience, this has been very similar to the typical patient. And so you can see that they have a relatively rapid improvement in their pain over the first couple of weeks and first month, and then some steady improvement over 3 to 6 months, and then some mild improvement that occurs all the way up to 1 year. And so this is what I'll actually tell patients in clinic is, you're going to expect to see some good improvement, although I'd say there's some variation in this first 6 weeks. By 3 months, you're going to see the bulk of your improvement, but can expect to see ongoing improvement at 6 months and up to 12 months. And we can see that the function really paralleled their pain scores as well. So there's been several other studies now that are in print and other ones that are accepted or in submission. Obviously, with any new technology, there needs to be lots of well-designed studies that look at the various body regions that confirm findings of some of these small pilot studies. And so the good thing is those are in the works at present. So we'll move on to kind of the main thing here that sort of sets the background, and now we'll move off into a little bit, of personal experience and anecdote. But I'll tell you what I've sort of learned over the last year and a half. And so in terms of sites treated, pretty much anything that you can reach with the device, I've probably treated at this point. And so elbow tendons, triceps, patellar, quad, medial hamstrings, Achilles, both at the substance insertion, plantar fascia. And what I found comparing this to what I was doing previously, which consisted mostly of needle tenotomy with or without PRP, is patients do seem to have a quicker improvement and less pain associated with the procedure. So it was not uncommon for patients to have pain flares that may even last up to 2 weeks with some of these other procedures, and that's much less likely now with the debridement with the TX device. The time frame has been variable. As I mentioned, the first 6 weeks is variable. I have some patients who are better within a couple of days, which doesn't necessarily fit with what we would expect from tendon healing. So obviously there's other mechanisms at play here, but certainly some folks will have those early responses. I have other folks who won't be better at all at 6 weeks and then really turn the corner at 2 months. And so there's certainly some variability in time at that point. But I would say that, similar to what we've mentioned in the prior published tennis elbow studies, about 80 to 90% of patients are seeing, substantial improvement and are very satisfied with the procedure at this point. In terms of complications, I've only had one site infection, and this was, I would even consider a pseudo complication. So this guy was a dentist, and he told me it was red, and he put himself on antibiotics without telling me. By the time I saw him, it looked pretty good, so I assume he knew what he was talking about. But outside of that, that's really the only problem that I've had to date. So in terms of patient selection, so first off, this is really for those chronic cases. And so if somebody has had symptoms for, 2 days, I'm not going to offer this as a treatment, obviously. In chronic, I think what we've sort of established, at least what's been established in the literature, is 3 months. And so I don't hold, to 3 months, on the nose or on the date. But for me, patients have to have had symptoms for a while, and then their exam and their imaging is consistent with a chronic process. And so, if somebody, and this doesn't mean somebody has, come to you and then you have to wait 3 months from that point. Obviously most patients end up coming and they've had these symptoms for a lot longer than 3 months. But that's sort of the main thing is really going to be the imaging findings consistent with a chronic process in my mind. We'd like them to have failed conservative treatment, and so what does that mean? Probably some relative rest and activity modification, particularly during the early phases. Physical therapy, I often will have patients do, although you can say that the literature doesn't necessarily support it for all of these indications. But I will usually have patients, at least have a period where they do go through 6 to 8 weeks of physical therapy before considering this. So at least anecdotally, it is often very helpful. In terms of NSAIDs, corticosteroid injections, those, I don't really consider that as conservative treatment anymore. It doesn't make a lot of sense from what we know about the pathology. And even in the case in the paper I presented earlier, people with corticosteroid injections and tennis elbow tend to do worse, and so I'm not really offering that as a treatment option at all, and I will move forward just with treatment with the TX prior to either of those. I want their history and their exam to be consistent with the problem, and I think this is probably the biggest the biggest thing to take away. And so there are masquerading and complicating conditions out there, and these are what you want to pick up, because these are the people who are effectively you're going to be treating the wrong problem, and they're not going to do well. And oftentimes they will have, what you're wanting to treat as well, but it may not be the main thing. And so what I mean by that is they may have tennis elbow, they may have chronic tendinosis at the common extensor tendon, but perhaps they have a radial nerve entrapment, and really that's what their symptoms are coming from. If you treat their tennis elbow, they're still going to have their radial nerve entrapment, and so they're not going to do well. Another example would be ligamentous instability, and so individuals who have a lot of varus instability at the elbow, are not going to do as well as those who don't. And so I think it's important to recognize those, and at least if you're able to recognize those on the front end, have the conversation with the patient. Then if they don't receive the benefit you're hoping for, you can say, well, we talked about this and we weren't quite sure how much was from this or that, and I think you still have this condition, and that typically goes a lot smoother at that point. In terms of what treatments they failed to date, I think that's very important to get an idea of what's been done. And so, one of the things I like to know is how many steroid injections have they had. If someone's had 12 steroid injections into their tendon, I do temper my expectations a little bit. I also want to know if they've had other similar treatments and how those have gone. And so the frustrating patients for me are the ones who come and they've had surgery performed on the area, and then they're sent to me for evaluation. So effectively, they've already had what we're doing. And so I think you really need to take some time to figure out, well, why didn't it work the first time? Was it the wrong diagnosis? Should you really be doing another procedure on the same spot? Was it poor technique? Did they just have a bad surgeon? Unfortunately, that does happen from time to time. Or did they develop a new problem? And so, is it the same pain? Is it the same thing back? Or did they have some sort of complication or just develop a separate problem after their surgery? If not, and if everything seems to fall in line and they just didn't respond, I will move forward with some of those cases, but I paint them in a little bit of a different picture. And so, I'll kind of refer to those as salvage cases, where I kind of tell the patient all bets are off in terms of what I can tell them regarding their potential improvement and outcome. We really don't know because they haven't seemed to respond to the treatment that they've had thus far. And so all things I think are important to sort of remember and go through as you're evaluating these individuals. And the other thing to remember is going to be patient expectations. And so these are really paramount with any type of procedure that you're going to offer. But I always like to throw this slide up. I think that shows this very well. And so this was just a study looking at patients that had a full thickness rotator cuff tear on their MRI. And it looked at, you can see the chart here looks at surgery-free probability and over time, over days. And so the numbers that you can see here, the 5 and 4.2 going down, represents their expectations regarding how well they're going to do with rehab, leading to improvement. And so if patients had a very high expectation that they were going to do well with rehab, they did well, and they didn't have surgery. The majority, over 80% of them didn't. If they had a very low expectation, most of these individuals went on to require surgery. And this was really the only variation. And so looking at severity of their tear, pain, and weakness, none of these were really associated with failure of non-operative management. So really the only thing that came out was patient expectations. And so I think this is very important. If someone comes to me and they have an expectation of a certain procedure, and they think that is what they need, unless I think it's the wrong thing to do, oftentimes I may entertain that just because of the fact that their expectations are really tied along with their outcomes. All right, so moving on to imaging, and so what should you do for imaging for these patients? So, obviously I think x-rays for almost all of these individuals are helpful. You're able to look for degenerative joint changes, calcifications, unexpected things that you may pick up on x-rays. And x-rays also are very helpful when you're interpreting your ultrasound images. So I do like to get plain films for these individuals. And then obviously the next thing would be ultrasound. What we're looking for in ultrasound is going to be a focal lesion that correlates with their pain. And so this is a common extensor tendon. Here's the lateral epicondyle. Here's the radius. And here's the tendon. And so, this area is very dark, obviously very abnormal even for those who aren't familiar with ultrasound. And the patient hurts when you push right here. You can feel pretty confident in your diagnosis. And these are the patients that are going to do well with the procedure. So by one finger test, what I mean by that is just, having them take their finger and point to the area that hurts, and then that line up right over the area of pathology. And that's the best case scenario. Ultrasound is also very helpful for procedural planning. So you want to know, are you going to be able to get the tip there? Is the device long enough for the region that you're looking at? Is there other structures in the area, neuromusculature and such, that you need to avoid? And so it's going to be very helpful to go through all that procedural planning on the front end. And then you also want to assess the stability of the joint. And so, this is just an example, as I mentioned, of varus instability at the elbow. And so as we put varus stress, you can see it's obvious gapping in the region. And so this patient, I sent on for surgery. They needed a lateral elbow reconstruction. They didn't, necessarily need further debridement. They kind of already had everything to breed it off. This is one of the cases of a surgery gone bad. But these people will come into your clinic every once in a while, and so you have to be aware of some of the things that you can do with ultrasound to help you out in terms of patient selection. MRI I don't feel is necessary for every patient. I probably do not get them on 90% of the patients that I'll see, but they are helpful from time to time, particularly if you are finding that your clinical exam and your ultrasound exam are not necessarily consistent, or you're worried about a possible intra-articular source of pain. Then MRIs can be very helpful. If you're not confident and comfortable performing diagnostic ultrasound, and you don't have anybody in your region who is, then certainly MRIs are very reasonable at that point to look for pathology, and then you can, then confirm that with the ultrasound for the procedure. But if you're not confident in your ability to make these diagnoses with ultrasound, then at that point MRI I think is indicated in some of these cases, certainly in cases that are very classic by history and by exam, I don't think MRI is necessary. So I wanted to mention briefly some of the features on ultrasound that you might see and things that that you should recognize. And one of those is calcification. And so calcification is seen very commonly associated with tendon pathology. And these can come in different flavors, and some of them are well treated, and some may be more challenging, and some may be a little off limits. And so I think it's important just to have an understanding of how to approach those. And so when you're looking at calcification, these are all examples of calcifications within the rotator cuff. And what you want to look at first is going to be the echogenicity. And so in this top video that we see this very echogenic, so meaning very bright structure that's sort of moving within the supraspinatus here. This is the acromion, and this is a patient who's trying to abduct their arm and really can't because of the impingement due to this large calcification. And we see with this calcification deep to it, so as I move my arrow off, deep to that, you're going to see mostly just black, and that's what we refer to as posterior acoustic shadowing. When you see this, you know that the calcification is going to be very dense, and this thing is going to be very, very hard, and as you can see in this patient, that's why they're really not able to abduct their arm. Now, if you look at the one down below, right through here, This has a much different appearance, and so it has a mixed echogenicity. It's much brighter, and you're actually able to see underneath it. You're able to see through it here. And so this is going to be more of the slurry type of calcification. So this is a toothpaste consistency type of calcium, and this will actually be able to be debrided and evacuated quite nicely, and actually easier than a lot of just tendonitic tendon tissue as well. And then there's all sorts of variations in between. So other things you can do are push on these, and so if you push down with compression of the probe on this, you're really not going to have much deformation, where on this you actually will have some deformation of the deposit, so that can be helpful. The other thing that can be helpful is just probing this with a needle, and that's actually probably the best way to do it if you're otherwise going to have a needle in the patient or do a procedure. And so what that would look like, we can see here, this is an example of an Achilles. Here's a calcific lesion, and here's our needle coming in. And you can see as you get your needle right on it and you push this, it moves the whole tendon. And so this thing is very solid. We're not able to pass our needle through it. And we know a lot about the tissue characteristics of this calcification at that point. This is an example of this same deposit after it's been treated, and you can see how our needle moves nice and smoothly through that lesion now. And you may come across lesions like this, natively, so these less dense calcifications that as you get your needle through, you're able to just pass it through very easily. And so, that's really going to probably give you the best information in terms of the consistency of these calcifications. So as we mentioned, these slurry-type calcifications are going to behave more like tendon. They're very easily treated, and you get very good outcomes with these. And so this is that same patient who had a couple different types of calcium within their tendon. And here's one of those slurry calcifications where the green arrow is. And so you can see this really has no shadowing behind it. It has mixed echogenicity, and this was easily aspirated. Whenever you see this intense hyperechoic surface, like here with this dense shadow, so this darkness that you can't see through below, these are going to be much harder to treat. And so this is the same lesion here that we're sort of moving, that's really socked in. And so these are going to behave, somewhat more like bone, because it's that very hardened calcium. And so these are going to be a little bit more challenging to treat, and make think twice about some of these. If you see this attached to bone, if this is really coming off of the calcaneus, certainly correlate that with your radiographs, but that may represent really an indecified or something that's more cortical bone, and those are going to be we would consider off-label. And so the device is approved for soft tissue indications, not really for bone at this point. And so if you see connection to that bone, it's very, very bright with dense posterior acoustic shadowing, I would probably stay away from those patients or consider that an off-label usage of the device. In terms of procedural technique, obtaining good local anesthesia is very important. I like to go in with a small needle, so a 27 gauge, 1.25 inch. That way I know if I'm coming in at the appropriate angle. So the device, those of you who have been doing procedures know it's not very long. And so if you don't have the right entry site, you're gonna run into trouble. And so I like to use a short needle just so I can feel good about being able to reach the region of pathology. As I mentioned before, I will use nerve blocks and occasionally for the plantar fascia. Plantar fascia, that region of the skin where you make the incision, pretty much irregardless of what approach you take, typically is fairly uncomfortable for the patient. It's hard to get that numbed up well with just local, and so I will typically do a nerve block for that. But that's the only routine procedure that I will use a nerve block for. Making an adequate incision, I can't stress enough. So this was one of the things I struggled with when I first started doing these procedures, is I just would not make a big enough incision. And that makes all the difference in the world. And so as you look at the device, this sheath isn't going to just slide nice and easily through the tissues, and the device is also not made as a cutting device itself, and so it's not just going to pass through these tissues like a needle. You really need to give it a track down to the area that you want to go. And so making an adequate incision all the way out, from the skin all the way down through the fascia into the tendon is really going to make the procedure go much smoother and allow you to get the device where it needs to be. The other thing to realize is that whenever you are trying to move the tip into different regions of pathology, you need to minimize how much manipulation of the microtip once you pass through the tissues. And so once you're through the subcutaneous tissues, obviously you're going to be passing through fairly thick fascial layers, and what that can do is it can cause some bending of that needle. And what we don't want to do is get bending of that needle where it's going over and connecting or pushing up against the sheath, because if that happens, then obviously the needle is vibrating very fast, and so that can cause damage to the sheath and can even put stress through that needle and can cause damage there as well. And so we want to really avoid how much maneuvering you're doing in the tissue. And so if you need to get to a different location, I recommend bringing the whole tip outside of the tendon, redirecting, and then making a nice smooth pass back into the region of pathology. And occasionally, if there's a very large area or there's multiple regions in a tendon, that may even require a second incision, and that's going to be better than trying to put too much torque on the microtip itself. In terms of energy time, this is variable. You'll sort of get the hang of it eventually, but my range is anywhere from 30 seconds to 15 minutes. And so for the average case, the run-of-the-mill tennis elbow where there's focal tendinosis, that may be 45 seconds. A patellar tendon or something, maybe 2.5 minutes, somewhere around there, depending. If you see some of those intertendinous calcifications, those are going to be kind of I call a gray zone here, and so if there's those softer slurry type calcifications, they may take a little bit longer if they're large, but somewhere in the range of kind of 3 to 6 minutes perhaps. Those thicker, more dense extratendinous calcification or those bony things, really again are off-label at this point, so I wouldn't recommend, going after, a Haglund's deformity or something like that at this point anyways. In terms of post-procedure rehab, so from a very broad perspective, it's sort of 2 weeks of rest and recovery. And so I'll protect these patients, pain and edema control, and range of motion. Protection is going to be relative. So obviously if it's a patellar tendon or an Achilles, I worry more about that than if it's a common extensor tendon at the elbow. So I will put those folks in a walking boot or a brace or on crutches, whereas a tennis elbow, often it's just, protected by telling them to not overuse their arm. At the 2 to 6 week point, that's their progressive rehab. And so what I tell the patients is we're trying to facilitate their healing without giving them a setback. And so we start working on and regaining their motion if they're not back to that point, working on functional strength and mobility. And I call this sort of the danger zone. And so this is an area that you want to avoid pushing too fast, even if the patient is feeling good, because they can have some setbacks here that I think over the long run, if you push them too quick in that early first 6 weeks, they can get some return to their symptoms and can ultimately have their total outcome set back by several weeks. After 6 weeks, that's sort of the return to play or the return to work phase. And so here there's a lot of variables. And so for certain individuals who are not overly active, they don't have a manual labor job, you may be cutting them loose at that point and telling them to go back to whatever they want to do. If they have a demanding job or they're an athlete trying to get back to sport, then this is wherever you're really going to be working with them closely on that return progression, working with, probably having them actually work with a therapist or a trainer or somebody. And there's also going to be dependent upon the region. So again, something like a patellar tendon I move much slower on than I would with an elbow. Even for somebody who has a high demand on that area. In terms of site-specific rehab progression, common extensor tendons tend to do very well. I do have a 5-pound lifting restriction on them for 6 weeks, but outside of that, I move them along pretty quick and pretty much as their symptoms allow. I'm not overly worried about them. The intermediate group for me is going to be the plantar fascia, the Achilles, and the other upper extremity tendons that you may treat. And so these we're moving along. We're not just letting them go back to whatever like I might for a tennis elbow. We're taking it a little bit slower that first 6 weeks, but really I'm allowing them to progress kind of as rapidly as they can after that point. The slow progressions in my mind are going to be your patellar tendons and quadriceps tendons, just because they do have a risk of rupture, and that's just not a good not a good area to have rupture. So you certainly don't want to have that complication. Even though we have not had that reported complication yet, I do worry about it. The Achilles insertion takes longer than the mid-substance. Mid-substance do very well. The insertion I find do fine for the most part, but it takes longer. It may take twice as long. So I just move them slower and I prepare the patient for that on the front end. And then also the workers' comp issue. And so, you can say all sorts of stuff about workers' comp. I've actually, that this procedure has gone fairly well in the workers' comp population, but I don't move them as fast. I sort of set up a reasonable, sort of slower rehab progression on the front end, and that's just how we move along, and that's made life a little bit easier for me. In terms of pearls and pitfalls, before we open it up for questions, I mentioned this a little bit before. There's an early responder. Avoid progressing this person too rapidly. So you do have to remember that pain and function and tendon healing and stuff, it doesn't always correlate. They're not all tied together. There's a lot of things we still have left to learn about that process. But pain-free doesn't mean normal, and this tendon healing does take time. And so there will be patients who feel perfect at 3 days. That's great. I'm happy about that, but I'm not going to let them play basketball at 3 days. There has to be a reasonable amount of time in my mind for that tendon to start healing in before I let them have that amount of load. The late responders, the other one, so it's the opposite end of the spectrum. Some people aren't any better at 3 months. It's rare, but some people, don't get better till 6 months. And so I try to keep these people moving along. I try to look at other factors that might be slowing down their progression. And so, are they doing what you're telling them in rehab? Are they, overweight? People who have a BMI of 60 are going to have heel pain. And so, I'm not overly optimistic on how well their plantar fascia may do. And so, are they a smoker? Do they have other medical problems? Those might take longer or might require a little bit different rehab course. And then there's obviously motivational factors in some of these individuals as well. The weekend warrior is a tough one, and so I've heard of some people, hopefully nobody on the call tonight, advertising back on the golf course in a week. In my mind, that's a recipe for disaster. And so, as we mentioned before, there's healing. This tendon healing takes time. There needs to be a reasonable rehab progression. Most of these folks have not been normal for months. They will require some period before they're able to get back, and I think it's asking for trouble if you're sort of advertising that they're going to be back that quickly, because you might get lucky every once in a while, but it will come back to get you. The athlete is another one that can be challenging. Here timing is really important, and some of these individuals, again, will expect a quick cure. They may think that this is, just going to be better in a week or so, and I really try to sell it to them as a surgery and timing it with their season, with their events. I talk best case scenario with them, telling them how much faster their recovery is going to be from a traditional surgery, but I also say, this healing does take time, and it might be 3 months. And I let them know that on the front end, and that's been helpful for me. Also let the coach and the trainer and everybody else know that on the front end, and that'll save you a lot of time. And then if they can move along faster and they progress more rapidly, then great. Then everybody's happy about it. But if you tell someone they're back in 2 weeks and it's 3 months, no one's going to be happy about that. And the last thing here is just going to be expectations again. So I mentioned this. I can't mention this enough. So I had a lady that I treated her Achilles insertion, and she came back for a 3-month follow-up, and I looked at all of her outcomes and her pain scores, and everything looked perfect. And I asked her if she's having any pain, if there's anything she couldn't do, and no, she could do everything. It didn't hurt at all. And then, I asked her if she was satisfied with the procedure, and she said no. And I was, I had no idea what to think at that point. And I said, well, this doesn't seem to make sense to me. You don't hurt. You can do everything you want. And she's like, yep, but I still have this bump on my heel. And that was, my fault for not, I guess, going through with her that, yeah, we probably won't get rid of this bump on your heel. We're trying to treat your pain and, improve your function. And so I'm very specific with my patients now exactly what my expectations are and ask them exactly what theirs are to know that we're both on the same page with that. So this slide, I think, just really shows where I feel, anyways, that we're moving with treatment of some of these musculoskeletal problems. Much like arthroscopy really, changed what we were able to do for many of these procedures. I think that the next frontier is really going to be, utilizing ultrasound guidance to guide these smaller instruments and these specialized devices such as the Tenex TX to these areas and provide a lot better patient outcomes. So we will open things up for some questions now and make sure everybody gets those asked. So I have one question on here. It says, how long do you treat conservatively before offering the Tenex procedure? And that's something we kind of mentioned briefly here. But typically, again, it's going to be 3 months of symptoms for conservative treatment. I usually will have people, maybe try a rehab approach if that's what we go with for about 6 weeks. And tell them if they're not seeing meaningful improvement at that point, then I'd consider the procedure. If they are seeing meaningful improvement, then we have a discussion about if we continue to hold the course, or if we, decide that their improvement is not moving fast enough, and we decide to move forward with the procedure.
Great, appreciate that. Next question came in, Dr. Hall. The experience in the lateral elbow. What has been in your opinion, ideal patient candidate for these procedures?
Yeah, so the ideal candidate is going to be, the patient who comes in, with chronic symptoms that localize really to the epicondyle. It bothers them with, gripping, lifting, not really a lot of, rest pain, no neurologic sort of symptoms. It seems like the diagnosis is pretty straightforward, and that the ultrasound imaging corresponds to that. So, they point to their lateral epicondyle and they say this is where it hurts, and you put the ultrasound there, and that's where you see the hypoechoic lesion, and you don't see any of the other things I talked about. So they don't have a loose elbow, they don't have a nerve entrapment. It's pretty straightforward. I would say that I get a little bit nervous to individuals who've had multiple steroid injections. That being said, I've treated plenty of those, and I can't say definitively that they've done worse. So, even though I, in the back of my mind, I have that thought that these guys might not do as well, they've been doing fine so far. I think, we need to have, larger studies to sort of bear out some of those nuances. But for me, I certainly treat those individuals even if the tendon looks kind of bad, and they've done well.
Got it. Thank you. Looks like we have a question from one of our physicians in the audience today. Do you have patients, Dr. Hall, that wear a specific type of compression boot? I had a patient who wore a cheap one and ended up with no pain from the plantar fascia, but ended up with, looks like PT, patellar tendinopathy.
Yeah, I hate boots, and I really do not like to immobilize my patients. And so after plantar fascia, I'm going to have them out of the boot hopefully within 5 days or so. And the Achilles, I base it somewhat on the amount of tendon that's involved and what my gestalt is on their rupture risk. But I try to keep them immobilized for no longer than 2 weeks, just because it's not uncommon to see similar things like that. So I don't have necessarily a favorite boot. My recommendation would be to try to limit how much they're in the boot. Try to get early mobilization, protect them only as much as is needed, and then start getting them moving again.
Thank you. All right, another one here. Is the current length, in your opinion, of the tip adequate for most of the rotator cuff procedures you've done?
It all depends on the patient size. And so if you have a thin patient, then you can certainly get there. If you have an obese patient or a very muscular patient, it's challenging. And it also depends on where the pathology is at. And so I would say that it's a toss-up, and depending on what your patient population looks like, it may not be most. I would say it's probably probably more of the minority of patients who I feel that you can, easily get to the rotator cuff. The length is an issue.
Appreciate that. All right, back to the elbow. What if you don't see the discrete hypoechoic area, but the patients are classic tennis elbow in terms of their symptoms?
Yeah, so those are tough. And so there's probably two things I would do for that. I would consider doing a diagnostic injection with just lidocaine in those individuals. You'll get two pieces of information from that. One, you'll be able to tell if you put some a little bit of lidocaine around or in the tendon, does their pain go away? If it doesn't, then you're searching for a different diagnosis. The other thing is sometimes patients will have small little partial tears within the tendon that are undiscernible at rest on ultrasound. And as you start to inject a little local into the tendon, you'll see it open up. And then it will become obvious that there's a tear in there that's sort of hiding. The other thing you could do is have the patient perform aggravating activities and exert it, and then that may actually bring those lesions out. Or, if everything else looks good, I would probably consider getting an MRI in that patient just to confirm, is there at least a little bit of signal in there? Is there something else going on? If you do all of that, and you really don't see anything, and I would base it on their response to the diagnostic injection. But I'm always very hesitant if I don't have an area of pathology to treat, because then you really don't know where you're going to put that microtip. So I do like to be able to identify a target and not just kind of put the tip in there and hope for the best.
Thank you. Okay. If you have a patient that self-identifies with pain in a particular area, has stated that they are chronic, would you still ask them to do conservative treatment before the Tenex procedure?
So that's a great question, and my practice has evolved over the last year in that. So when I first started, yes, I sort of said everybody needs to do conservative treatment because, before we do an intervention, this and that and other thing. Today, I think I've done enough of these procedures. The safety profile has been so good. The outcomes have been so good that if somebody comes in with chronic symptoms that have been there a long time, I will have the discussion with them on the front end, well, we could do this conservative treatment, or we can move right forward with this if everything fits. My rationale behind that is I do have a post-operative protocol that basically takes them through what they're going to do from a conservative treatment standpoint. And so I feel like it's reasonable if they've had symptoms for 2 years, they haven't gone away. Certainly they've already tried some relative rest and activity modifications and such on their own over that time course. I think it's fine to go ahead and move forward with the procedure.
Great. Now, this next question refers to the motion of the probe in an actual procedure. Is the motion with the probe back and forth proximal to distal in the elbow versus side to side? And secondly, and in the tendinous elbow, how wide is the zone of debridement?
So the motion is back and forth in a proximal to distal or kind of inline or longitudinal with the tendon. And the motion really of your hand is fairly minimal. So the device, the tip is vibrating, on its own, and it's doing its own thing. And so you're sort of moving it back and forth just to make sure you're coming down to touch the tissue, debriding it, and then you sort of move it away to allow for the irrigation fluid to kind of aspirate back through and clear that needle tip. So it's a very small orifice, and so it can get clogged up if you just push it right into the degenerative tissue. So it's a subtle back and forth motion to sort of help clean that tip out. And the zone is going to be variable. So basically the area you treat is the area that you see. And so you want to use orthogonal imaging planes, so both a short and long axis, and just make sure that you get the tip to the entire region of pathology. And so the dimensions are going to be variable from each patient. And so that's where you use your ultrasound to identify that zone and then make sure you get your tip there to treat it.
Great. Can you please touch on how you know when you're done, particularly plantar fascia?
Yeah, so that's a great question, and that's something that I struggled with for the first couple of months of doing this. And sometimes it's very easy. And like the case that I showed of that patellar tendon, whenever you can really see the tissue evacuated and you're just starting to see the irrigation fluid moving around with the little bubbles inside of a hole, you're done. That's pretty straightforward, and that's the ideal case. Plantar fascia rarely is like that, and that's one of the more challenging ones to know when you're done. And so what I would recommend you do is start getting a sense for the feel on the needle tip. And so even though you don't get the same feel as you might from a needle, you will get some feedback from the microtip as it goes into the tissue. And so once you first get into it, it will be very firm, and then after it's been debrided in that location, you're going to be able to move that tip back and forth through that area with more ease. And it's somewhat subtle at first, but you will pick this up over time. The other is really once you get the tip to all of the hypoechoic regions and you've adequately been to each of those spots, I mean, at that point you're probably done. The device does its work quickly right at the end of the tip, and so once that millimeter sphere at the end of the microtip has sort of reached the whole area of pathology, at that point you're really done. In areas where there are some of those subtle calcifications and such within the tissue, those will go away. For the most part, you may still have a little bit of superficial, kind of shadowing from that. You may still see a little bit of debris left from that, but it's going to look a little fluffier than those very bright hyperechoic areas. And so those are probably the best tips. It is something that you will become more comfortable with the more you do. I think paying attention to that feedback from the passing of the tip through the tissue, as well as just making sure that you reach all of the pathologic areas with the tissue will kind of be your best guides for that.
In the context of this current question, can you expound a little bit further on how there is no real defined time in terms of the procedure, and the times referenced so far in your presentation are really data points and not rules for deciding when you're done, when you're not done?
Yeah, and again, I think this is, with any new technology, these things, will need to be worked out. And so my guess is over time, as more of these are done and more data is collected, we may be able to provide ranges, but I do think there's individual variation in tissue. And so, I don't think it'll ever be a point where, the lateral elbow is 45 seconds, the patellar tendon 63 seconds. I mean, I just don't think, I think there's too much individual patient variation to get those sort of numbers. And and it's been variable even in patients who have a similar appearance on ultrasound. I felt like some take longer than others to sort of achieve those endpoints that I was just describing, that for me right now are what I use. And so I know it is a little frustrating that it's not protocolized in that regard, but I do think that it's too much variation and just not enough overall experience reported for us to be able to give more specifics.
Thank you. All right, looks like we've got one more here. Question from the audience. Do you perform ultrasound, diagnostic ultrasound, on everyone in the office before the procedure?
I do, and as I mentioned, a large part of my practice is diagnostic ultrasound only, so I get referrals in just for that, and I'm very confident in my ability to do the diagnostic ultrasound. So for me, it's often in lieu of an MRI, and then we may proceed. I certainly would recommend a pre-procedural scan for some individuals that are a little bit more challenging, just to make sure, if you like for the person who brought up the rotator cuff, you may consider at least doing a scan to see what the feasibility of the procedure would be. So if you have an MRI that already shows your pathology, you could do like a feasibility scan just to make sure you're confident with it. But if you have an MRI showing the pathology, you don't feel like the diagnostic ultrasound is going to add anything, and it's just for the procedure, then I certainly wouldn't wouldn't bill a diagnostic ultrasound or necessarily perform a full diagnostic ultrasound. It would just be utilizing it to guide the procedure.
Thank you for that. Well, it looks like we've wrapped things up here a few minutes past the hour. I don't see any other questions. I'll give it last call for anyone who has one they'd like to put forth. Otherwise, we will conclude things this afternoon. I want to thank Dr. Hall for his time. This has been a fantastic presentation. I hope all of you have enjoyed and found this a worthwhile use of your time. Should you have any follow-up questions, please contact your local representative directly. We can get them to Dr. Hall and get a response to you. So again, thank you for joining. Appreciate your time. Enjoy your evenings. Thank you very much.
All right, thanks, everybody.